Good morning. Welcome to this second session on health in the World Policy Conference 14th edition. This session, as the previous one, is a follow-on of the WPC Health workshop that was held December 2nd, 2020. It was an online workshop. As the first one, or the previous one, was focused on lessons learned from the pandemic, the COVID-19. Here we will continue the conversation and say, okay, what structurally could we do when it comes to health, covering the aspect of technology, the economic, and ethics. On the panel today, I'm very pleased to have colleagues I had on December 2nd, notably Mr. Jacques Biot, former president of the École Polytechnique in Paris, currently board member and advisors to companies on digital and artificial intelligence, who will speak first. Then we have Professor Daniel Andler, Emeritus Professor at Sorbonne University, a member of the French Academy of Moral and Political Sciences right now. You heard yesterday, was on the panel with me, Carlos Moreira, former UN expert on cybersecurity, founder, chairman and CEO of WISeKey, a Swiss-based cybersecurity company specialized in digital identity, and we will hear more about this and data. And I'm joined today by Song-Woo Kim, former faculty researcher at Harvard Medical School, CEO of MiCo BioMed, a Korea-based biochemical, immunological, and molecular diagnostic company. The structure of the session today set the scene, the context, first with Jacques and Daniel about the economics, the context of the healthcare market, and the ethical aspect. Then, of course, we will go into more practical aspect with our entrepreneur, Song-Woo and Carlos, and I will conclude before opening for question around some consideration regarding what is common in technology in healthcare and what is not common with the rest of the technology fields. Without further ado, I hand over to Jacques for context setting.
Thank you, Patrick, and good morning, ladies and gentlemen. First of all, many thanks to Thierry de Montréal for organizing this beautiful conference. I'm learning a lot with my numerous hats, and so thanks much for that, and congratulations. Actually, I spent 30 years of my life working on market access issues in the healthcare system and trying to carve out the value of therapeutic innovations, both for society and in economic terms, to make them solvent. And my talk today will address the difficulty of reconciling supply and demand in this ever-burgeoning field of healthcare services and products, and to suggest potential ways to introduce some strategic drive to maximize the benefit for society, because actually the field is not driven by any invisible hand, and this is why governments find it very difficult to regulate healthcare. So we'll give a quick look to what is demand and what is supply in this field. On the demand side is enumerable in real terms. The International Classification of Diseases, which is established by WHO, lists a total of 55,000 different codes for as many disease definitions, of which about 7,000 to 8,000 orphan diseases, and each and every patient expects that a cure will be brought for his or her disease. In economic terms, this concrete demand is made solvent in most cases by payers or insurers, whether public or private, whether monopolistic or commercial and competing, who account for a major chunk of the expense. So the patient often doesn't pay much. And overall, the public contribution to health expenditures reaches 60%. It varies from 24% in low-income countries to 71% in OECD countries, but it's growing 1% faster than GDP almost everywhere. And those expenses are almost systematically considered as a constraint, as something which governments don't like, regardless of their positive impact on the economy, both because they contribute to reducing the burden of disease, which otherwise would have a cost in terms of illness, and also because there is the value added of providers and suppliers, which has to be taken into account in terms of jobs, progress in technology and manufacturing. Which leads us to look more in detail to the supply side. And we've seen that the demand side is extremely scattered. The demand side is just as scattered, as much scattered. You have a few leading players in the provision of care, like the National Health System in the UK. But in most cases, providers are still very small, very fragmented organizations. In the US, the top 10 US providers of care were responsible for only 18% of all inpatient days in the country. And this provider universe, which is highly job intensive still, and we may talk later on what can be done to improve the productivity, has very low profitability, mostly in the low one-figure percentage, although some outliers can, I would say, provide much higher returns. And productivity is decreasing globally. I mean, this has been pointed out by a number of studies. In the pharma industry, fragmentation is very high as well. The leader owns about 5% of the total prescription market. In the medical technology industry, the top 10 companies own about 40% of global market share. So this comes in strong contrast to other technology-driven industries, such as aerospace or information and communication technology or the GAFAMs. And this is something on which we could think, I would say, I mean, I have some ideas on the reasons, but we don't have time to elaborate about that. Contrary to care provision, the pharma and medtech industry do enjoy lofty returns on capital, but again, the profitability is decreasing for some number of reasons, one of which being the fact that they enjoyed those lofty returns because they carried a high level of risk, and the evolution of the field today leads to put the risk on the shoulders of mostly VC-funded companies, startup companies. Today, more than 50% of innovations are brought forward by recent companies, young companies, which have been very innovative. So again, a big change in the structure of the industry. Now, what does the supply side provide the demand side with? Mostly innovation. Keep in mind, today, at this time, there are about 350,000 clinical trials ongoing in the world, of which almost 300,000 are interventional, i.e. aim to measure the effect of a given intervention. So in summary, thousands of diseases, hundreds of millions of patients, thousands of care providers, and hundreds of suppliers offering myriads of solutions. And who is regulating this in economic terms? And my answer is, at this stage, there is very little strategic insight, and this is why expenses are looming, and people still are unhappy with that. Now, you can only regulate what you measure, and this brings us to ask which metrics are available. So I'm not going into a course in health economics, but keep in mind that epidemiologists, health economists, clinicians have tried to find a way to compare diseases between each other. So they've defined what are called disability-adjusted life years, quality-adjusted life years, but this doesn't provide you with the view of whether you should rather treat disease A rather than disease B. And it's the same for clinical trials. So I'm not going to go into this, but let's keep in mind that there is really plenty of thought to be given to how to measure the impact, the effect of care on society. And this brings us very often to ethical issues that will be discussed by Danielle. So when it comes to curbing healthcare expenses, payers are left without much clue as to how to do this in a strategic way. and most of them oscillate between a variety of cost control schemes. Again, I don't go into the details, but most of them are just cost control schemes, and they don't consider expenses as an investment, and they don't say which preference society would have. So this is the reason why more and more voices in the academic community call for a more rational, data-based, socially acceptable strategy to be concerted amongst healthcare stakeholders, including patients, because as mentioned, the patient is central. He often doesn't have much say as to how he's treated, but he's asking for more say in this field. As a patient, he feels that remedies should bring to his ill whatever he's suffering from. But as a taxpayer, as an insured person, he doesn't want to pay for everybody else, and so he's really kind of in a schizophrenic situation. And at the macro level, no institution. I mean, there was talk earlier on about the role of WHO, but there is no real institution vested with the role to define and the power to enforce a strategic distribution of resources to the innumerable health interventions that patients request individually. So my plea, and I will finish with that, Patrick, is that the time has come to reinforce research and education in epidemiology, in health economics, that the fast improvement of data collection and the management of data using high-performance communication and augmented intelligence gear should allow for a more informed, consensus-seeking definition of public preferences in terms of health policy, and this could serve as a basis for the allocation of public resources to all healthcare players. And I would like to pay a specific tribute to my African friends in the room, because there are a few exceptions. I mean, there are exceptions to everything that I said, but there are a few exceptions to what I said about the lack of management. I'm a great admirer of what Rwanda has done after the war to rebuild an efficient and intelligent healthcare system. I heard yesterday that Senegal is going into that direction. And I think Africa, again, in this field, like in others, may pave the way, and I would welcome this effort. Thank you very much.
Thank you, Jacques. We'll not summarize, but just for the Q&A session later on. So you raise a question mark on matching supply and demand, visibility of profit over time, regulating the unknown, and patient versus client. Some of the points that you raised in your presentation. Thank you very much. You mentioned the point of ethic. So, Daniel.
Thank you, Patrick. Yes, indeed. We could almost have a chorus where the two of us would be talking about things, Jacques on the economic side, and I would talk on the ethical side. They're very, very interlinked. So I'll make 3 points. I have 3 parts at my very short presentation. One, I'll say a few general things about ethics. Then I will say a few things about why technology within healthcare changes things. And finally, I will try and show why ethics and technology at this point don't go very well together, and what we could possibly, why we would want to change that. So ethics is important in healthcare. Now, not for the simple reason that, people have a human right to health, and that therefore it's our individual and social duty to provide this health care. Ethicists are not around to belabor the obvious. Ethics comes in whenever the path forward is anything but obvious. As the philosopher Joseph Raz said, ethics seeks to give substance to the general category of the good. Now, this sounds very philosophical and abstract, but it means that all these issues that we've just heard of are issues which raise ethical issues, difficult issues that need to be slowly but surely belabored. So why is ethics central to healthcare in very general terms? Well, because on the receiving end are people who singly and collectively have a lot at stake are a captive market and are vulnerable. When you're sick, you're vulnerable. And because all along the chain that provides healthcare, there are workers and stakeholders, we've heard about some of them, that have ethical exigencies and put ethical constraints of their own. Yet, ethics in healthcare is difficult to conceptualize because health is a highly contentious good, subject to variable and often conflicting interpretations, because health and healthcare depend on economic, political, social, and mostly cultural factors, and because there is no direct route from principles to practices on the ground. And finally, because the ethical demands of the different stakeholders are not always aligned. Ethics is a lot about dilemmas. Ethics is also, in the sector of healthcare, hard to implement because on the providing end, in both public and private arenas, the budgets are enormous, as are the opportunities for enrichment, because our understanding of the biological and sociological determinants of health are still patchy, raising issues of permissible risk, because research and clinic are intermingled, yet pursue different agendas, raising serious conflict of interest issues. In fact, the whole field of bioethics arose because of these conflicting views of research and the clinic. Finally, because the digital age, thus governance, turns governance into a global affair. So I come to my second point, technology, which is in the process of bringing about a sea change in healthcare, both, and that's absolutely obvious, as direct benefits for people, but also, and that's maybe less stressed, as tools for democratic participation and ethical debate. But technology also opens the door to entirely novel practices which raise equally novel ethical issues. And the more powerful the technology, the more areas it can penetrate, the more outlandish and possibly transgressive the practices. I don't know if I have time to give just a few examples very quickly. Think of genetic engineering, the issue of germline modification, the funding and ownership of very rare diseases, the issue of enhancement, and the threat to fairness and equal treatment. Second example, the commodification of DNA sequencing raises a series of ethical conundrums bearing on privacy violations and incidental findings when you find out that you have a genetic defect and maybe your kin also have that defect and that wasn't planned. You were not expecting that piece of news. Patients' consent for therapeutic or palliative use of sensors, cameras, tracking devices, robots, raise issues for non or partially competent patients. I'm thinking especially of the aged. E-health can lead to the accumulation of untoward amounts of personal information on some or all members of the population, with the attendant risk of surveillance and control or unequal protection and coverage. Generalizations of systems of e-health can cause increased inequalities, either because the underprivileged lack access or the minimum skills to navigate the system, or because only the more opulent sectors of the health system can afford the best up-to-date information and apps, or again, because personal face-to-face care might increasingly become a privilege. You've all heard of progress in intensive care technologies that lead to insoluble end-of-life problems. The UK has at present 150,000 comatose patients that it doesn't know what to do with, except just wait and see. That's a lot, 150,000 patients. Progress in neuroimaging lead to intractable problems with comatose patients. And finally, a whole set of concerns arise from the enormous costs involved in the deployment of digital systems, medical equipment such as surgical robots, discovery of drugs for rare disease or vaccines against new viruses. These issues cannot be settled in advance, nor can they be put off once the technology is entrenched. See Facebook, too late. They must be resolved on the fly as new possibilities arise, new expectations crystallize, new values emerge. Each step requires both broad consultation and time to be, so to speak, ethically digested. And both are lacking today. Democratic consultation. At present, the responsibility for developing new technologies rests on a minuscule group of people with exclusive access to knowledge, power, and money, and who answer to virtually no one. And as far as time, the ongoing competition for dominance between inventors, entrepreneurs, mega corporations, and countries does not give a chance for the new forms of good to take shape. So, the technological race must slow down while the structural conditions and effective tools of democratic control emerge locally and globally. Now, asking technology to slow down is a little bit like asking a tiger to go vegan. Yet there are hopeful signs. There is pushback. There's a meeting such as this one. There are many initiatives around the world, both official and legal and constitutional and private, that are trying to slow down this race and to orient it on the fly towards better treatment of healthcare. Thank you.
Thank you, Daniel. Always a pleasure, insightful and inspiring. I really enjoy. I catch the technology being a tiger getting vegan, so I'm really good to see it. We'll make the transition and ethics on the fly. Moving on the response or the perspective on technology, we'll have two aspects now. One linked to the medical technology and the other one to the information technology that supports the environment. We will start with Sangwoo on the medical technologies, please.
Okay, thank you for giving me a great opportunity to discuss about these big issues. So I'd like to focus on three issues. One is that prevention versus treatment. And second issue is the massive screening versus point-of-care test. Thirdly, I'd like to mention about the innovative point-of-care test to ubiquitous healthcare. The one is that in USA, the National Institute of Health, NIH, they invested huge money for over 50 years on the cancer drug development. But after they said they couldn't find any progress, the ratio of the patient was almost the same after or before the investment. And then they made some conclusions. So they changed their policy to prevention rather than treatment. Then so many pharmaceutical companies changed their the future or the investment the direction. Now the prevention means include the vaccine development or the diagnostics. This field is very important. If you prevent the disease before the treatment, will be much effective. Actually, it seems that it is more effective. And last year, we have a pandemic, a COVID pandemic. In the beginning of last year, WHO announced that pandemic started. But each country tried to get the right detection systems. So in Korea too, many diagnostic companies generated so much the PCR diagnostic kit and also the machines. and provided for the massive screening. But the massive screening has the one critical problem, transportation of the human samples. After you get the samples from the hospital, you have to transport. Usually it takes a long time. So that is also a cost. And also during the transportation, your samples, in the beginning, the sample for the transportation, they made a very special packaging, 3 layers of the special packaging, not to spread out the virus. So that was made much cost, and also made a mistake, also a mix-up of the samples. That kind of thing made some wrong result for some people. But for the massive the screening purpose, it was fine. But if they had a point-of-care test system on that point, also still now, then they can handle the sample on site. Fresh samples can be analyzed, and then we can provide the data very quickly without any cost or the duration time for the transportation. It will be a great method, but still, we are not ready. So nobody made a so compact, accurate, inexpensive system. But maybe the government, also every company wanted to generate that kind of inventions. So that is the one critical point. And then why? How can it handle the supervising the disease at this time after the corona or with the corona? So possibly, if we can, this kind of point-of-care test system at home or in a private hospital, then you can use this one more efficiently and then more effectively. So for this, we need some special technology. That is, we need innovative technology. So how can you make them? So I think the government should make some policy to generate this kind of need technology. So we need a huge investment for this. So many companies are trying to make this one. But in the beginning, mostly new technology comes from the venture, the startup companies. They concentrate on the new technology. They wanted to make it commercialized by the help of the big companies. So there, the startup companies cannot get funded well. So who's going to sponsor them? The government may need this kind of sponsoring system. So if they can get enough money, enough investment and concentration, they can make a very fast, accurate, compact, inexpensive, portable systems can be generated. If that is generated, we can use this one at home or at any place in the field. Then those they can collect the data on site. They can send this data result to the hospital or to the control tower. Especially in the control tower, in the servers, whole data can be collected. Using this big data system, we can be assisted by artificial intelligence. Using this kind of a combination, we can estimate the next disease or what kind of disease will appear in different season, different location. So this one will be the good approaches. So many companies wanted to approach this way, but still we need a critical part, innovation. So I like to focus and emphasize this innovative technology. In this way, we can apply to the ubiquitous healthcare the future. So everybody can use a handheld size or wearable size of detection system at home, and then they can track their health, and then they can provide this data to hospital. Then they can collect in the government or control tower, the center for this control. They can provide a good policy to to control the disease and for the better life. That will be the, I think, future world. So if I provide one simple the cases, we are working with WHO, and also we are working with Institute of Pasteur in Senegal, especially in Senegal. They adopted our system. We are co-developing together. They have the huge number of the clinical samples from the African countries. And we have some innovative technology we provided. We could make a very efficient way of the point-of-care test system. So, and then we hope we can make a better system together. And also WHO, we are communicating with the WHO. They also, providing us the good information and guidance. In that way, we can find the real need from the real world. So we hope we can make this kind of the cooperation for the good solution. Thank you so much.
Thank you, Sung-Woo, for the practical proposition. On the previous panel, we heard that one of the lessons from the COVID crisis was the need to better anticipate and the need for the preparation. And if I understand well here, you're proposing a priority that says the preparation should lead to ubiquitous or instantaneous healthcare, and this requires also the type of infrastructure that you describe, and definitely cannot be built overnight. So thank you for this input. Continuing on this, because a lot resides on data, Carlos, our identity and what we do with privacy.
Thank you very much. It's again a pleasure to be with all of you in this panel. We had opportunity to discuss that remotely via video conferencing. So yesterday during my presentation, I raised the issue of and concern of not making the human as a center of gravity of the fourth industrial revolution. So human needs to be in control of everything that is happening around humans and not the other way around. Now, one thing which is a highly concern for human is health. It's actually the health of the human, right? We are not talking about something which we should not be concerned. It is our health. And who says it's our health, it has to be everything else. It should be our data, should be our consent, should be our identity, should be our control. Now, what has happened, if somebody in 2019 will have said that one day we will be providing bio data at the same time that we are showing our passport, at the same time that we are giving our mobile phone, at the same time that we are providing our geolocation, they will say, this is crazy, will never happen, right? So this is exactly what is happening today. We are every day, every time, every airport, every hotel, every facility, we are actually doing that. And this is creating a situation which could get out of control very fast. Because I mentioned yesterday about the issue of social media treating humans as a consumers. But in the health industry, a patient is actually a consumer. The health industry lives on the patient, right? Sicker you are, more money the health industry is going to make. So behind all that is always a fight between who should own that data. Now, the data process from collecting data from as simple as a COVID test all the way to the cloud, all the way to the analysis and back again to the response includes many players, and many of them, they are not secure. And as a cybersecurity expert, I always analyze every step of the security. And if one step is le maillon faible, it's the one that has no security, the entire chain is compromised. 3 weeks ago, the United Nations was hacked in Geneva. Last week, many major multinationals has been hacked. The hacking is becoming an industry. The dark web lives of that. So it is so easy to compromise and hack a health industry organization that will not be secure enough to maintain the data. So what happened? The happen is that all that data goes to the dark web, all that data is then commercialized, all that data is available for hackers to further hack you. But there we are not hacking only our financial record. I mean, we could lose money, or we are not hacking or, eventually consumer behavior. Here we are hacking our health. Here we are hacking our bio health. Now, the problem of these applications, and WISeKey has been observing something like 60 apps, traceability apps, including the Swiss app, which, by the way, was rejected by the Swiss population because the security was not there, is that they're so easy to hack. I mean, those apps that we are downloading in our mobile phones, they are, at 99% of the cases, not cybersecurity friendly app and tested. So that means, for instance, they are not using digital identity. They are not segregating what we call the PII, personally identifiable information, who you are, what is your blood, what is your DNA, all that data, which is supposed to be only under your control and consent, is now being provided together with your identity, which makes no sense because we have technology now like blockchain that allows you to segregate that. You can take your PII and encrypt under your consent, and then I can give all the medical data I want, but I don't want that medical data to ever be related to me, my PII. My PII is myself, is owned by myself, and it's like the key of your house, right? The key of your house is your key, and eventually you give to somebody because you invite that person into your house, and you provide to that specific moment and person the consent to access your house. But you don't give the key for always. You don't give the key unconditionally. That's what we are doing on health. We are giving our keys unconditionally. So the way of solving that is already there. One of the things that has demonstrated the COVID pandemic is that countries that they manage to fight the pandemic through a sophisticated digital transformation strategy, part of the fourth industrial revolution, they are actually moving away of the pandemic with an amazing track record, protecting their citizens, protecting their health, and protecting their economies. Countries that they were not ready, they are actually suffering, and they are suffering a lot. And this is not only developing countries. This includes many European and even the United States, many states and others. And the reason they are suffering because the digital transformation has not been taken serious. So as we move forward into the fourth industrial revolution, these principles then, they have been very well tested, and humans have been able to defend many crises, wars, atomic challenges and others. We had technology that was there designed to avoid that all these ends in the wrong hands. The COVID situation, and I mentioned yesterday that in 20 years' time, when we will look back, we will have forgetting about the pandemic and the COVID, but we will have realized that it was actually in 2020 that the world entered into a dangerous phase where our information is being used without our consent. What is going to happen next? So as I mentioned yesterday as well, technology are converging. So now you have AI, which is getting expanded with quantum computing and unlimited computing power with amazing amount of data. AI needs data, right? AI without data is like a children without education. AI needs data. And if the data is a data which relates to us, human, AI will analyze this data with our control. The extension of AI, which is what we call it, the singularity on AI, it means the moment where one computer, and we are about 20 years to that singularity moment, one computer will be more powerful than one person mind, and more intelligent than one person mind. And 5 years later, the same computer will be more intelligent and faster thinking than the entire collective human minds put together. That moment of singularity, we don't know what is going to happen. I mean, computers will maybe see us as a very slow, very unhealthy humans, and therefore we need to be enhanced. And I tell you, one of the industries that they are expanding on the health, and this is the #1 industry now in many countries, is longevity, is the possibility of extending the human life. I know many friends in Silicon Valley that they made a lot of money in technology, and now the only thing they think is they want to live 120 years or farther, and for that they will do whatever is necessary to enhance themselves. So the creation of this superhuman or human with unlimited health capability and resilience is something that is contributed by the amount of data and amount of information we are giving to those algorithms. So the solution, as I mentioned yesterday, is very basic. It's go back to giving the human the control, putting the human in the center of gravity. I fully agree about your chart of instant interconnectiveness. 5G is going to allow that. In 5G environments, your house is going to be a laboratory. Your toilet is going to analyze real-time your bio situation and bio behavior. You're going to be tracked real-time, and you're going to be able to send that information, but under your consent. The important thing, as I mentioned before, if we do not give to the human the possibility of having a final say in what data they produce, final say on whether they want or not to indicate their PII at the same time they discloses the data, we will get automatically into abuses. Now, technology is there. PII can be encrypted. This is what our company does. Blockchain, and we had this discussion yesterday, decentralize the information in a way that it is impossible to hack because it's decentralized in all the computers and they are part of the block. Once the data is minted, either through NFTs or any other technology, that data cannot be extracted, therefore cannot be modified, cannot be manipulated, and it is under the consent of the person. So I believe that this is also a business opportunity to the health sector. The health sector needs to apply the latest technology, and the health sector, by doing so, will advance faster, but they will need to abandon the thinking that a patient is a consumer. Thank you very much.
Thank you, Carlos. I think it makes the link also with what we heard yesterday on François' panel on technology post-pandemic, and with Professor Suzuki presenting us the initiative on Japan related to managing global data sets, creating a strategic advantage by the ability to leverage artificial intelligence. And for sure, this will be one of the tools that we've not used well in the current crisis, and that will definitely help to address some of the unknown, to discover some patterns that we might not figure it out ourselves in the way it evolves when you have so many unknowns. So I think it's it's definitely an area where we have just started to look at it, and I agree with you. We have all these silos, and this has been pretty mismanaged so far. So can we get our act together and have a good approach to this data set? I think this will be a difficult path. I would leave for the audience the question of transhumanism aside. It's not part of the debate, please. So it's another question, or otherwise I will have to give the word to Daniel again for a very long period of time. So that we'll leave this aside for the time being, but on the data set, I agree. I would like to, before opening the floor for question, make some comments about the link of technology in healthcare and the link with technology in general. All innovation have to go through a 3 points checklist. First, it has to be socially acceptable. That's the point number one. If it's not, it will never happen. And we've seen how difficult it is in the healthcare space, the divergence of interest. So, but that's one of the screening, and probably what makes technology adoption, innovation adoption in the healthcare very difficult, because this is the social acceptability. That's point one. The second thing, it must be economically viable. And Jacques presented the challenge of matching supply and demand, the infinite possibility of supply, but also the infinite needs from very rare disease and others, and how you're going to organize this match, the lack of visibility on future return that hamper. So I think this is the second test. And the third is the technical feasibility. And here, paradoxically, this is where we see less problem. I think we're not short of ideas on how to do things, on how they could be done. But I think here in healthcare, we struggle in particular with the first two. And these are the challenge, I think, even from a technology standpoint, where we should focus. Looking at this, and you look at the evolution, how technology has been designed, we started by product-centric design. That's how it has been done. If you think of information technology, processor, the Intel is Eve at our technology era. You do the product. We heard yesterday about from François about Moore's law, and that was a product-centric design. I have to produce, and I will figure out the demand, and I will create the demand. This era is over, and we moved with the rise of the internet to a people-centric design. Unfortunately, so far it has been a very consumer-centric design, where when you are the object, you have to wonder what it means to you. But that's a reality. And here in healthcare, we have this duality that has been expressed by my colleague on the panel of is a patient a consumer? Certainly not from different aspects, but certainly yes from many other aspects. So, but we are still in this paradigm of consumer-centric design. We know, we sense it, but we have not moved yet, that this time is over, and we need to move to a planet-centric design. We heard it from Mr. Siegel this morning in the previous session, the importance of there is no health in a healthy environment. So that was clear. I'm not the expert, I believe in it as a patient. So, but what does it mean? And if you look at the adoption of technology and how to evolve, include these parameters from product to consumer to planet-centric, there is one very interesting aspect to approach it that I like personally, is to look at the question of the negative externalities. Because it's known in economy, this is a parameter that is not taken into account. This creates huge distortion on the debate around climate. And I can only recommend the book by Professor Christian Gaulier from the university, the School of Economics in Toulouse, called Climate After the End of the Month. And that's a very interesting thing about also the paradox on, okay, I have this long-term equation that is impacting me short-term, but it doesn't materialize at the end of the month as well. So because I still have to pay my bill, I think in France in particular, and we see it again with the price of energy, and this is a very difficult conversation, but I think including negative externalities in the equation of technology design is a must, just period. You have to do it, find a way, because if you don't move it, the old paradigm of consumer-centric will lead us into the wall. It's leading us currently, by the way. The last point is, of course, performance. So you've noticed these 4 Ps, people, product, people, planet, and performance. We love acronyms in technology. And I think Jacques evidenced the problem. It's the visibility on the return, but also the acceptability of the return. I mean, when you have a breakthrough in technology, when you look at the GAFAM, these are very high amounts, some would even say insane amount of profit. That gives you, when you have Mr. Zuckerberg welcoming Prime Minister Modi and say, this is the 3rd and the 4th largest state in the world meeting, you wonder if really Facebook is a state, but he said, yeah, I have 1.3 billion users, so I mean, it's almost as big as India. That creates some distortion and rejection of the population about the technology evolution. And I think we're at a phase right now in our society, and this has been evidenced by another professor of economy, Carlota Perez, on the economy, the financials of technology, that shows there is always a cycle where there is this huge development that is understood only by a few, that makes a lot of money, and then there is a crisis of trust. We heard the question, and then society needs to reappropriate technology because they have as I often say, a bigger problem to solve than the ego of some of the big tech CEOs. And I didn't mention one in particular. So that's the thing, and I think that's the perspective on technology. So the parameters are here, but it's a complex equation. But I think what is good is we've learned a lot, we've built assets, and now we understand the parameters. So if we get together with some more of a holistic views, we should be able to map some ways forward and anticipate, as was said before, and prepare for the future. So I'm rather on the not utopian but optimist side of the technology. So that's for my contribution. We have some time for a few questions on technology, ethics, and economy in healthcare. Yes?
Thank you very much. My name is Randy Coty. I'm a graduate student at the Kennedy School and an incoming French public servant. My question is, during COVID, we've seen how technology has become a key and strategic capability. But the question is, who should develop those technologies and who should own them? Should it be the private sector for maybe efficiency concerns and also for the fact that there will be more independence on that? Or should it be more on the state side for ethics concerns, actually? Because people would maybe trust their states more in some places, or in other places would be more Apple, Facebook. Thank you very much.
Thank you. Jacques, you want to take the question? You take this question?
Yeah, well, thanks for the great question. Actually, I think I gave a pretty pessimistic view of the relation of the system, but there are good news, and the good news is that there is there's big reservoir of productivity due to augmented intelligence. So, which will make, which would make it possible to get rid of many of the inefficiency in the system. Now, the question of who owns that is a big question, you know, and again, we lack time, and I think this would be an encouragement to Thierry to go ahead with more thoughts being given by IFRI to healthcare issues. I currently have a project, for instance, which leads to roll out artificial intelligence into pathology, and the question is, who owns that? Is it the engineer, the physician, the people who provided the data which made it possible, the hospital, etc. So it's a big question. We don't have much time. I think in the end, the profit has to be shared between the various players. Once again, the good news is that there is a reservoir of productivity, and so we should all work together, first of all, to see how it is possible to really grasp this reservoir and how we share it in an intelligent way and in an equitable way. So I defer this question to another meeting, Thierry, if you are interested in going ahead with this theme.
Okay. We have a question from Michel, as chairman of the previous panel. I wonder what you have to.
Thank you very much. This is a question to Dr. Kim and Carlos Moreira, maybe. I think beyond the technological progress and beyond the issue of consent, I think what you've been talking about is a major revolution to me, which is that these technologies will lead to self-responsible management of health by the people. Until now, the patient somehow, and the name patient, the word patient is speaking by itself, was a passive object versus the healthcare system. Now the patient will become the responsible actor. And that, of course, has a lot of implications in terms of what's his source of information and whether we should leave the decision to the patient. And I wonder whether you can comment on that.
Can I go first?
Yeah,
So,
is that a question for me? Or,
yeah, I will go first. Actually, in the diagnostic field, there is a self-testing system. The rapid immunoassay kit is one of the example. So, and the FDA have a process for the self-testing, for clear test, clear waived test. That kind of things can be done by simple process. For example, if you have the 1 drop of blood, and then you can see the band, 1 band or 2 band. If you have a single band, that is negative. If you see the double band, it is positive. Very simple photo determination. That kind of simple system can be applicable at home.
If I just completing the answer, I think that it needs regulation. The fact of moving from passive, which is what we should be, to be an automatic, like default login into somebody assessing our health, is something that can only be resolved by legislation. You know, there's HIPAA regulation in the United States, there's other regulation in Europe, but actually it's very vague in who owns the data. The data should be owned by us, by the patient, not by the system. If we own the data and it's under our consent, then we have a protection, as we have everywhere else. We have in the financial system, right? And the bank is not authorized to do anything without our consent. That level of consent needs to be installed in the health industry. Now it's not the case. Now the data belongs to the health institution, and this is wrong. The data should belong to us. And we can give them their consent to use that data. If the data belongs to them by default, then by default, we will let artificial intelligence and other technologies to data mine that data.
Okay, thank you. I think we come to the end of the session. Thank you very much to my colleague panelists on the insightful presentation, for your question. And as we have the boss in the room, I would not dare to overrun, so thank you very much.
Yeah.